Welcome, and thank you for joining us today. I'm Caroline Roberts, General Counsel and Senior Director of Public Policy at Children at Risk. I am so excited for our Motherhood Roundtable today and to hear from our panel of experts. The purpose of today's event is to equip stakeholders, service providers, and mothers and support people, anyone involved in the process of giving birth with the tools they need to advocate for women's health and for their own health. As a new mom myself, I am so looking forward to learning from you all. For those that are new, Children at Risk is a Texas nonpartisan research and advocacy nonprofit dedicated to addressing the root causes of child poverty and inequities. Our mission is to serve as a catalyst for change to improve the quality of life for children through strategic research, public policy analysis, education, collaboration, and advocacy. This event is hosted with some fantastic partners. So in partnership with our Texas Family Leadership Council, a collaborative of family serving organizations across the state, but then also with the AFIA Center, Delta Sigma Theta, March of Dimes, Paradigm Doulas, Southern Roots Doula Services, Texas A&M's Women's and Gender Studies Center, and Trust Her. Thank you so much for all of our amazing partners. A little bit of housekeeping. You can view the agenda for today's program and get to know our speakers using the links that were dropped in the chat. If you have any questions, and I'm sure a lot of you will have questions, I urge you to submit those for our speakers using the question and answer function. We will, especially after the panel, have some time dedicated to Q&A, but even if your question is not answered, we will try to make sure that we answer it in the Q&A function. So with that, I am going to start off by sharing a resource. Sorry, can you go back one slide? So Children at Risk, in partnership with the aforementioned partners, put together a resource, a pamphlet for expecting moms, again, support persons, anyone who is giving birth or helping someone to give birth. And one of the reasons why these kinds of resources are needed is that there is a serious lack of access to healthcare in Texas. So Texas ranked 49th in access to maternal health care as of 2023. Lack of access to care puts mothers and children in danger from the start. There have been some positive changes, such as the extension of Medicaid coverage to 12 months postpartum in the last session, but those are only recent changes. And even though there might be Medicaid available for 12 months postpartum and during birth, we know that there are many barriers to uptake of that service. And so there's so much more outreach and communication that needs to happen with those expecting mothers. There's also a lack of prenatal care, both care during pregnancy, but also care before conception. So prenatal vitamins such as folic acid are important to take leading up to and during pregnancy. These vitamins and prenatal visits are covered by Medicaid and CHIP, but again, those who are trying to conceive might not know that. There's also the need for counseling. So understanding the screenings that you might want to consider, lifestyle changes that might affect fertility and pregnancy outcomes. This type of education has historically been really neglected in the US. The resource also covers some data points. So one really shocking data point is that 1 in 4 women report feeling ignored or dismissed by healthcare providers during their pregnancy. We want to see improvements on both sides of this relationship, both on the patient and the healthcare provider side. So we know that healthcare providers have experienced a ratcheting of pressure in the past few years. They also experienced a lot of trauma during the pandemic that went largely unacknowledged, or they didn't have time to take a break. All of that is building upon itself. However, mothers have a right to understand what is happening to their bodies, what their choices are, the different birthing options, the different options for pain management, and what to consider in making these decisions? What is the data? What are different experiences that women have had? And really have the time to talk through these choices. They also deserve to be heard when they actually voice concerns, voice symptoms, voice how they're feeling. And as is clear by this data point, that 1 in 4 women feel ignored, we feel that there could be some improvements on how these conversations are happening. Although this is an issue across the spectrum, we know that some populations are especially affected. So especially affected by adverse events related to pregnancy, such as maternal morbidity and mortality. And we're going to talk about those today. Maternal mortality rates are a staggering 69.9 per 100,000 for Black women, as opposed to 32.9 for the general population. And I can give you these data points, but I also want to honor the fact that communities of color have been lifting this issue up for a very, very long time. They've been sharing their experiences for a very long time. And, progress has been exceptionally slow, if at all. We have to get these numbers down across the board, but especially for women of color. When we look at the numbers compared to other wealthy countries, the US is doing by far the worst. Luckily, our experts today are going to talk through some of the causes of these disparities, as well as some of the solutions. You can also use our resource, and you can find the link in the chat for some legal resources. So there are links to Texas Law Help, the Birth Rates Bar Association, as well as some data and research, the National Maternal Mental Health Hotline, and a few other things. It's important to know your legal rights. So Pregnancy Discrimination Act, what FMLA entitles you to, understanding whether you qualify under FMLA. Is your employer employing 50 plus employees? Have you worked there for over 12 months? And then also, what do you perhaps qualify under Medicaid, CHIP, and other programs that are there to support those in need? With that, I'm going to turn it over to Michelle Harrell. She is the Maternal and Child Health Assistant Program Manager with the Harris County Public Health. And she is going to give an overview of some fantastic Harris County Public Health resources that are also aimed at helping women to understand their rights and what resources they can tap into. Michelle?
Hi, good afternoon, everyone. Thank you, Caroline, for the introduction, and thank you, everyone at Children at Risk. I really do extend my sincere gratitude for inviting me to participate in today's roundtable discussion. And the reason why I'm so eager about this opportunity is really to shed light on the impactful initiatives that are underway with the Harris County Public Health. And just to provide a bit of a background on how we got started as a program here at Harris County Public Health, it's really just a direct response into the pressing issues and the maternal health challenges faced in our communities. And with under the astute leadership of Director Robinson and the Harris County Commissioners Court, they actually allocated $7.7 million of ARPA funding to establish the Maternal and Child Health Program, which I do oversee as the Assistant Program Manager. The program is readily committed to provide resources and education and really enhance the healthcare access to families that are residing here in Harris County. The overarching objective of this program is to really mitigate the risks that many birthing families go through. And we want to be able to empower these families to establish the robust foundation of their health and just having an overall healthy start with their families. It's Our program is just really easy and really open to all of our families in Harris County, and the requirements for our program are very little. You must reside in Harris County, be currently pregnant, have delivered a baby within the last 12 months, or have experienced a pregnancy loss in the last 12 months. So with that, we are able to provide just an overall comprehensive support with personalized in-home visitation and just really cultivating the strong parent-to-child relationship. We have a great community health coordinators that actually go out into the homes and connect families to resources, whether it's internally through our Access program or through our maternal and mental health program, or even WIC, or even outside resources with the connections that we've made with grassroots organizations. And essentially, our community health coordinators really do provide direct support to our families for up to 3 years. And through these endeavors, we aim to really foster or help foster a healthier and more resilient community for generations to come. And we hope to continue to be a really great supportive factor for our families and our birthing persons, because this is a public health issue. We want to make sure that we do our best to take care of our families here in Harris County. Um, We've come out with lots of initiatives, one of them being the Maternal Health Bill of Rights. And with this Bill of Rights, it comes as a Z card, and I'll show you all what that looks like. It's the size of um, a card, and families can open it up and see what their rights are when they are in the doctor's office, or just overall exploring what they have available to them. But I'm really happy to be here and really excited for this panel, because this is a really important topic to discuss, and a lot of our families need the support that we're able to provide. So thank you again for having me.
Thank you again so much, everyone, for joining us. With that, I'm going to turn it over to Dr. Nicole Townsend, who is our fantastic moderator for our next panel.
I can't access my camera. It says that the host stopped my camera.
Sorry, guys. Some technical issues. Let me see.
Yeah.
There we go.
Hello. Thank you for that. First, I want to take this opportunity to thank the Children at Risk and all the other participants for allowing me, as a member of North Harris County Delta Sigma Theta, to actually speak on a topic that is so near and dear to the core of what we stand for in our community. So thank you to Children at Risk, and again, the other panelists, Deandra Willis, Dr. Teresa Morris, and you also, Michelle. So thank you very much for having me this evening. This afternoon. I want to, we're going to have a panel discussion, but before we do that panel discussion, I just wanted to take the time to introduce our panelists. So first we have Miss Deandra Willis, and she is the full spectrum doula and childbirth educator, Southern Roots Doula Collective. She also works with the Birth Justice Program as a lead at the FIA Center. Next, we have Dr. Teresa Morris, who is a professor of social and women's gender studies, director of women's and gender studies program at Texas A&M University. And you just heard from Michelle, who is the maternal health assistant program manager at Harris County Public Health. So welcome everybody, and thank you for joining us today. Ladies, I'm going to start with some questions. I'm not going to direct it to a specific panelist. Please just raise your hand or just Take your mic off if you feel comfortable and confident answering that question. The first question, could you describe the state or the current state of maternal health in Texas? What are the most pressing issues that you feel need to be addressed? And then lastly, what strategies do you believe have shown promise in addressing these issues?
I can start. So again, I'm Deandra Willis with the Fear Center, and I think this is one of our most focal points in the work that we do at the Fear Center. I do have the privilege of leading our birth justice program and also have the honor of working with community as a community full spectrum doula. We know that in the most recent years, the state of maternal health in Texas have been under increased scrutiny due to the variety of pressing issues that need urgent attention. The maternal mortality rate in Texas has been on the rise, placing the state among as the highest country, as we heard earlier. This alarming trend has brought to the light a number of significant challenges that need to be addressed in order to protect the health and well-being of expecting mothers and their babies. As we know, Black women in Texas are significantly more likely to die from pregnancy-related complications than their white counterparts, highlighting significant disparities in care and outcomes. In my opinion, one of the key approaches is to expand access to affordable and comprehensive prenatal care services, particularly in those in the underserved areas. As we know that we received the 12-month extension on the Medicaid, but we don't always consider some of the social determinants of health that they are experiencing and the lack thereof even before the pregnancy. So, it's almost like they're getting pregnancy already at a deficit because we are not tackling the most rooted issue in that. So it's a lot of reasons, a lot of things and strategies that we can implement here, but I think the most pressing thing here will be to acknowledge that we need to address the root cause.
Thank you for that, Deandra. And as a specialist in women's healthcare, I am especially appreciative of doulas and midwives. And we can actually, studies have actually shown that that is a key strategy in mitigating maternal mortality, is having that alternative method of delivery and also having that be covered, right, by private or Medicaid insurance. It's really, really important. And I know that there are some works of that on the rise. So I'm really hoping to see an increase in support of doula care services, because as a former labor and delivery nurse, I absolutely loved working with doulas, and they actually made a change in our birthing outcomes. So thank you for being here, and thank you for answering that question. Because Texas is, like you stated earlier, pretty high on the list, right? Our rates are pretty high. We're one of the highest states nationally that has maternal outcome rates that are pretty poor. Next question. This one is tricky because this is kind of the core of what we are discussing here today. So my next question is, how do racial and socioeconomic disparities affect maternal outcomes in Texas? And what strategies can be implemented to reduce those disparities? Dr. Morris, yes, thank you.
Well, I want to say that Deandra has already talked a lot about those disparities.
Yes.
And so we know, like with maternal mortality, we know with preterm birth rates, with low and very low birth rates, that there's always a racial disparity in those, with Black moms having the worst outcomes. And one thing I would say is that in terms of how can we address that is we need to take seriously the study and move it away from the women. So it's easy when we see race as a factor to say, right, it's about the women, but we all know that race is socially constructed in a way, and that it's not about being Black, it's about the way that being Black is in the United States or in Texas. And so contextualizing that out to be, what is it that makes Black women more vulnerable rather than Black women are more vulnerable, if that makes sense. So I think
Yes.
if you start to think about, how do I do spatial analysis? How do I look at where women are living in terms of why they have higher rate, these negative maternal outcomes? Like, is it where they're living? Is it the care they're getting? Is it the doctors they're seeing? Is it the hospitals they're going to? And you start to take it away from the women in terms of like the blame. I think I worry so much when we talk about individual characteristics that make women vulnerable, that then we forget that it's all of this stuff out here that is causing that vulnerability. So I think one of the things is to recognize that. And on mortality, it's, you know, for the Maternal Mortality Board, the Texas Maternal Mortality and Review Commission, to actually study every maternal death and not a sample, right? And
Yes.
to study every maternal death and to figure those out, and to really then say, how can we prevent this? And one of the things I know from knowing people on maternal mortality review boards, I want to be on the Texas one. I have an application, but I know you have to apply many, many times to be on it. Is that what we don't recognize is that some of those maternal deaths are due to suicide after the baby is born. And so how are we sure that we're helping women after they have babies, and we're thinking about their mental health needs? How are we going to work to prevent that? And how do we just acknowledge it as a society? Because I think everyone on this, like on the panelists, knows this, right? That this is an issue. But I don't think most people do, because it's not something we like to talk about, because we like to assume when a mom has her baby, this is the sociologist, I'm a sociologist, this is the sociologist speaking, we're all socialized into the norms of motherhood. We're to be happy when we have a baby. We're to, you know, celebrate that. And we're not to make it about ourselves and to say, I'm having trouble, because that makes you, in society's views, a bad mom, right? If you center it on yourself. So I think there are many things that we can do, many kinds of data we can use to try to address these interventions, and different, you know, ways we can think about this and really center on women's experiences without too much forgetting, right? It's not about individuals, it's about what's going on out here that is making them at risk.
Thank you, Dr. Morris. And I'm happy that you mentioned that postpartum support is a key factor in maternal mortality. A lot of people assume that maternal mortality happens at the time of birth. Like this woman has a baby and then she dies in the hospital, and that is wholly incorrect. We measure maternal deaths, or you can define maternal mortality as a maternal death that occurs up to 42 days after the birth of a child. And a lot can take place after the 42 days, right? And so that's why it's important for us to even understand what maternal mortality even is, so that we don't forget to look at those moms outside of those 3 or 4 day delivery or recovery mark, and kind of go out past that 42-day mark, and even now out of 1 year. From the clinician side, we actually look at these patients for a year out, which was why it was critical for Medicaid to be extended out to 12 months, because we were missing that mental health screening opportunity, that we maybe have missed that in the prenatal period. So that's really, really important that you mentioned that. So thank you very much. Okay, next question. We're moving along. So what role, this one is near and dear to me, what role do healthcare providers, including midwives, and doulas, play in improving maternal health outcomes in Texas? And what barriers currently exist for these practitioners? Anybody want to address that one or answer that?
Hi. Yes. So, I really wanted to also, if I could piggyback off of the last question as well, I wanted to point out that Harris County has the largest disparities for Black women, Black pregnant persons, and the sad part about it is we have the largest medical district in the world.
Yes.
And right in our backyard, we have so many families suffering, and for things that could be So I really wanted to just mention that, and also just mention that as a public health department, I mentioned before that it's a public health issue. There are things that we as a department need to make sure that we're able to do for our citizens. And one of the things that we are aiming to do to prevent a lot of these maternal deaths are to really provide supportive health care and helping get families into services that would help address any.
Uh-oh. Is she having difficult, if she paused for everybody? Okay. Well, for the sake of time, I'm gonna give her a few more seconds and then I'm gonna maybe come back to that question.
Years.
Uh-oh, Michelle, are you back?
Yes, can you hear me?
Yes, we can hear you now. Thank
Oh
you.
no. Okay. It's raining. I don't know
I
what's going on,
know.
but so I don't know where I left off. But I do want to say that as a large entity and with working with grassroots organizations and other community organizations as advocates for our communities, we have to make sure that we connect our families to education, to provide just overall awareness of what you mentioned earlier, Dr. Townsend, is mental health, prenatal care, postpartum support. All of these things need to be addressed, and just overall advocacy for policy changes to support our families. One of the things that I'm not sure if I mentioned previously for our program at least, we provide support to families that are enrolled for up to 3 years because we know that after the first year, there are still things that our families need, and it doesn't stop as soon as the 12 months are over after postpartum. So just continue to be an advocate for our families, and as a representative of a large entity, I'm also an advocate and supportive of anything mental health, and just wanting to make sure that we continue to do that.
Okay, thank you so much for that.
Can I
Kendra, did you want to
chime
add
in?
anything on that?
I do.
Yes, I figured so.
Yeah, so the biggest thing is so I work with a lot of community programs, and I think the biggest thing that we always miss out is that a lot of these disparities are caused by systemic racism. We do have these programs. A lot of time, the programs that we are implementing, we want them to help, and the intentions are for them to help, but it's a lot of barriers put in place for the community. I have sat on a lot of community advisory boards that supposedly, was built to help with lowering the rates of maternal mortality and morbidities, but it's not given to the people that it's highly impacting the most. And so we have to acknowledge that systemic racism is the overall issue here that causes the barriers, that causes the disparities. I also want to acknowledge that yes, doulas and midwives save lives and they help with practitioners and work alongside the practitioners, but it's the lack of education that the families have to even know that that's an option.
Absolutely.
It's a big gap there in educating. And so, and I'll also say as a Black doula, a lot of the weight of lowering the mortality rate and morbidity rate is on the back of Black doulas. And without with the lack of finance support, being able to be paid by insurance or included in Medicaid, you're going to find the disparities. You're going to find a lot of the things that are impacted. Birthing people is going to impact doulas also. And so we have to always see systemic racism on the table and address that and see how the impact of social determinants of health are impacting the communities and addressing what that should look like. And once we do that, and then we increase provide full access to healthcare, comprehensive healthcare, I think that will start the ball to rolling, where the programs that are created for the intentions of improvement will do exactly what it's meant to do. It will help with those numbers.
Absolutely. As I continue to do the work in this area, I come into contact with a lot of OBGYNs or OB-GYNs, as they call it in the South, who are in the forefront of this fight. And one thing that we talk about as clinicians is that we are going to have to garner the support from the physicians to say, hey, we are in support of using nurse midwives, educating their patients to say, hey, although you have access to me as a physician, you also have access to a certified nurse midwife who is clinically trained to deliver your child. You also have access to doulas who can work in conjunction with those midwives and even the physicians. And it's not even necessarily about, a competition, because what we know now is that there is a shortage of qualified, culturally competent physicians, right? We know that there's many OBGYNs out here that can deliver babies, but in order to impact this patient or this population demographic, they need to also be culturally competent. And so that these patients are feeling safer when they go to see them. And that if someone says, hey, you may be afraid of the hospital, but here is a certified nurse midwife that may be delivering in a birthing center that I support as a physician, right? Because we know they need a medical director. If something goes wrong in those deliveries, that they have a place that they can go to in the hospital where there is a continuity of care, therefore mitigating the maternal outcomes, or I should say improving the maternal outcomes, right? So thank you for that. Next question. This one's a little tricky because this one has almost put a magnifying glass on what we're talking about today and all other healthcare disparities out there. So how has the COVID-19 pandemic, impacted maternal health services and outcomes? I don't know, Dr. Morris, you want to take on this one? I think you might have.
Yeah, right. I haven't studied COVID in pregnancy very much, but I do know that particularly COVID did lead to more community births and out of hospital births, as women didn't want to go into the hospital. I have a good friend who had a baby at the beginning of April 2020 and was going to have a hospital birth and ended up having a home birth in short order because the physician who was going to deliver her baby was doing time in an ER, doing rounds in an ER. And she said, that's not what I want for my baby. So I know that we had that. So I will say that in terms of COVID, that's what I know most, is just that it supported a community birth, so birth center births, home births, and both CNM certified nurse midwives, as well as community midwives, certified professional midwives doing those types of deliveries. Yes. So we've seen more resurgence of home births and birth center births, but without the data in front of me, I hate to comment specifically on COVID and pregnancy. So I feel like you might be better as a clinician to talk about that part of it. So I'll talk about the social part, which is, that we've seen more there,
yeah, I do have some insight on it, but I just didn't know. Michelle, do you have any data on that?
I was trying to find my mute button. Sorry about that. So right now we do have the maternal and morbidity rate um, documents out, but we didn't really study the effects of COVID. It's still pretty new, and so we are still taking some time as a public health department to try to research that. So I don't have an answer right now, but hopefully the next few years we would be able to have that information available to the public. But I wish I had an answer, but right now we really don't.
Deandra, did you have any input?
I don't have any numbers, but I have experiences because I never stopped supporting moms during COVID, right? Luckily, I was a mom who had a baby. I had a pandemic baby at home. I can say that the impact that it had on me, because I was pregnant at that time, was really drastic, because I was supporting moms who were scared to go into the hospital. One, because of COVID. Two, because the lack of support that was not going to happen. So I had to be a doula over the phone. And then three, because the people had, like, people were at home. So a lot of reading had happened. So a lot of people started to learn a lot about maternal mortality. And so it was the coupled effect of birthing in the hospital with COVID, on the strength of that I may not come back home because I'm birthing in the hospital. And so that impacted a lot of moms mentally. We're still serving moms who are still impacted because of COVID. I can say that it exasperated poverty for a lot of the people that we serve, because it's still a luxury to birth out of the hospital because it's not covered by insurance. And so you still have moms who are still dealing with that out-of-pocket fee, or just a lot of health, a lot of health inequities that they're dealing with it from the COVID impact. So whereas I don't have the numbers, I still deal with moms who are still dealing with the impact COVID had during their pregnancy and just other illnesses that happened during that time.
Yeah,
That's
and so, something
great.
Deandra said about, and I love the experience because I think that's so important to hear what that experience is. It just reminded me too of the women in the hospital not having any support, right? There being all these barriers depending on the hospital policy on if anyone could come in to be with her, doula or family member. And so the effect that had for, really a couple of years on women giving birth in a hospital with very little support, like what you were saying, Deandra, that doing a doula over the phone, right? And so I think that was one effect. And I wonder about, how did those policies, and I don't know this, but I wonder about, were those policies when we were kind of, post-COVID, we're not really post-COVID, but, post-COVID in terms of people being with you in the hospital, are they not as generous as they were pre-COVID? And I don't know, and I wonder about that. So when you restrict who can come, does it mean that you keep some of those restrictions because they made it a little easier for the hospitals? I don't know, but that would be interesting for me to learn.
I can just tell you that, being, a former nurse at the bedside, and still having some connections to that, those support systems have been relaxed in what we consider maternity services. So because we know that in order to be culturally competent, in order to deliver that care, you kind of have to leave the door open for whomever that patient wants to be there as their support. Because what we do know is that it does improve outcomes when they have the people there that they want to be there. So many years ago, when I was practicing at the bedside, there was no amount of people that could be in there. There was no number. There was only a number of people that could go back in the operating room with you. So yeah, so they have completely relaxed that in the hospitals back to kind of how it used to be. Just to improve patient outcomes. And we know everything is based on surveys, right? So they want those survey numbers to kind of go back up because those survey numbers are directly tied to reimbursement. So yeah, I'm going to go ahead. I think we did talk extensively about that because I want to leave the floor open for questions later. And so we're going to move on to the next question. This one is kind of, let's see, how, Deandra kind of touched on this, and so did Michelle. What roles can community organizations and advocates play in improving maternal health outcomes? And can you share some specific examples of effective local advocacy or programs?
So some of the roles that organizations can play improving outcomes are just being connected to what's going on in those communities, staying focused on that, providing education. I'm really big on families being informed. That's what empowers them. Part of the FIS and one of our programs is our doula collective, Southern Risk Doula Collective, where we train doulas. We invite them into our space, our laboring space, where they're able to serve, able to educate, and not only for just birthing people, but it's beyond the birth. It's also teaching sex education. It's also being able to connect to holistic providers for families in the community to just come in and be a part. I would say for those that are in the work, being a part of the CAPS community advisory boards and giving and lending in your expertise of like what you see, what you know, and being able to shape and inform those programs that's going to directly impact our communities.
Thank you. Thank you. Michelle, did you have any programs that you could identify?
Yeah, so I wanted again to speak on our program, the Maternal and Child Health Program. We really do go and do like a door-to-door outreach. So we go out to homes, we'll go to um, different outreach locations, specifically targeting any zip codes that would have a large influx of high morbidity or mortality for infants or pregnant persons. And so we really strategize on what we do in outreach. We aren't limited to who we see. We see anyone in Harris County, but again, we do want to make sure that we focus or try our best to focus on the families that really need our services. Um, and you know, the rates for mortality and morbidity, there's no monetary value on that. There's no, you know, there are people of all races, of all socioeconomic statuses that have difficulties. And so, because of that, we really do strive to make sure that we are providing this support to all of our families. And additionally, we have a lot of internal programs within Harris County Public Health that we're able to connect families to. We're very intentional in making sure that we're connected with diverse populations because Houston is a melting pot. And so we one of the efforts that we've talked about earlier is the Maternal Health Bill of Rights, and that comes in different languages. And so just little things like that really do drive to make a large impact. And so we really do strive to make sure that we are getting connected with our community a lot more. Dandra mentioned the Community Advisory Board. We also have that. We want to make sure that we listen to our local experts who are out in the ground, doing it, making sure that they're listening and being the advocate for their families. So just overall making sure that we stay connected and it not become where we're doing separate things. We need to make sure that we're coming in together and providing just an overall support for health and the well-being of our communities.
Thank you for that. Dr. Morris?
I just wanted to add a few resources for the Bryan College Station area. Two I'll highlight. The prenatal clinic is a clinic in Bryan, Texas that provides free prenatal care to women without health insurance, and that includes undocumented women. There's also a state social worker who is at the clinic who helps women fill out applications for Medicaid or CHIP if they're undocumented, and then provides care to them for 9 months. They partner with the family physician medical students at Texas A&M's medical school, and also some of the certified nurse midwives at the School of Nursing at Texas A&M. So I like to highlight that. And again, that's for women who don't have health insurance. There's also Texas A&M School of Nursing runs a nurse family partnership, which is a national program, but we have one at Texas A&M, and that is home visits by specially trained registered nurses that start when a mom is pregnant all the way until the child is 2, and they focus on women who are low income and are first time moms, and so who may be most at risk for these negative maternal health outcomes and child outcomes. And so those are a few of the resources in Bryan College Station that I just wanted to highlight.
Okay, thank you, ladies. Also, my social action chair, Dr. Monica Cook Brown, here at North Harris County Delta Alumni Association, we really pride ourselves on focusing on areas in our communities, such as maternal health. And so last year, we created a tool specifically for the state of Texas that has, it's a living document, if you will. She's about to include that into the chat. So if you click on it and download it, anything you hover over any little box, it takes you directly to that website. So that should be in the chat here shortly. Oh no, she doesn't have access to put it in the chat. So I will get that tool out. I don't know if she can put it in there as a question or somewhere in the Q&A, maybe that that we can include that because it has lots and lots of services. Oh, you can put it in the Q&A? Okay, you can send that to the Q&A, Dr. Monica. And it has all sort of local and state organizations and community services that you can take advantage of. Okay, so then also obviously Mark the Dimes and the Texas Black Mamas community collectives are all great places where we can get some resources out there to our moms, all moms. I'm gonna see my next question. I'm gonna see if we kind of talked about this already, so I'm gonna skip that one, and I'm gonna go to our final question so that we have time for some questions for our participants. And I think Deandra and also Dr. Morris, you kind of mentioned this as well earlier. How do you feel education, well, let me rephrase that. How can education about maternal health and rights be effectively delivered to the expected mothers? That's critical, right?
Well, I'll say that one of the things that I do as a Texas A&M faculty member is the classes I teach a few gender and health, reproduction, birth, and power. I teach a senior seminar that often deals with women's health. And I always cover women's reproductive health in those courses. Basic information, I have a childbirth educator come, give basic information about reproduction and childbirth. We talk about just different social disparities, inequalities. We talk about access issues. And I always say to, kind of think about this. I approach this as a sociologist, but I also, what I'm doing is I'm talking to mostly young women, and they're going to think about things differently, right? After they've had a class like that, but they also talk to their friends. And so I am not the main one who educates, but there are different ways to think about education. And as a professor, that's somewhat how I educate. I also take my students on field trips to birth centers and things like that to just familiarize them. So that's indirect, and some of you do much more direct, like childbirth education, but I see us, kind of different ways of education, thinking more broadly.
Thank you.
I actually think that is a really good idea because that it actually catches both perspectives of it. So from practitioners' standpoint and as expecting mom, they will eventually be expecting moms or they working with expecting moms. But what like my personal if it was a perfect world would be to catch them when you first establish your relationship with your OBGYN. I feel like before they are expecting, this information should be given to them. They should start learning because it makes the pregnancy even better because they are informed before, or once they arrive to the day that, okay, I'm going to do this parenting thing. I already have my tools. I think we're working backwards when we give it to them once they come in to say that they are expecting. We're definitely working backwards. I will also say, as a community doula, as it relates to funding organizations that do the work on the ground. A lot of times, as working in a nonprofit organization, we get the money second or third hand. So it's given to a big organization, then it's funneled down to those that are directly working with the community. So I would say funneling money to organizations that are doing direct service work and helping to disseminate that information by different ways, not just social media, but just like Michelle said, door to door knocking, social media, in the books, like just covering all grounds of how we can get that information disseminated to the people.
Thank you so much for that. Those are great answers and great feedback. And Deandra, I'm so happy that you touched on what we call preconception. It's because a lot of people, or a lot of women, don't know that really when you are in that stage is when you really start to have to seek that education, right? We know people think that when you start taking prenatal vitamins is once you're pregnant. Well, we would like for you to take them 3 to 6 months prior to becoming pregnant, right? A lot of people think that they, like you said, finding out these things once they are already pregnant, getting that pre-genetic counseling. There's a lot of communities that don't even know what that is. They don't understand that it's important to know who you're going to procreate with, because the outcome of that could, cause many issues down the road. But there's a lot of people in our community that we just don't know about that because we weren't taught that from very early ages. And there's a real thing called generational curses and things that we do just because that's what we've always done. It's just because it's a lack of education. And not only that, just a lack of tools that are out there. So with the tool that we all worked on for today's event, it has an immense amount of information. And one of the areas that I worked on kind of talked about that preconception. So in that tool, and I'm not sure if they've shared that yet, it's a beautiful tool. And I feel like it should be available to just every person out there, women and men, because we know that our community does consist of not just mothers, right? Because we know maternity mortality affects everyone in the community, not just the mothers. So I think we got through those questions. Let's see how we're going to kind of navigate through. I know there's lots of questions. I just kind of peeked over there and saw that there are lots of questions in our Q&A session. I'm going to try to spend a little bit of time. We got a little bit behind, but we have some great information and some great feedback. Carolyn, would you like for me to go ahead and start asking those questions, or how do you want to handle that?
Yes, feel free to just go through the Q&A, whatever sticks out to you.
Okay, looks like this one is answered about the resource. This one says, I'm an advocate at a nonprofit organization. We serve women, and the majority of the women in our program are moms or expecting moms. What can we, as support outside of the family and healthcare, do to best support the moms we serve, either during pregnancy, birth, or afterwards and postpartum? Hopefully you got some of those answers here today from the panel. If you did not get those answers, please can you put it in the chat and I'll give you some specific feedback. But I think we answered a lot of those questions during the panel. Let's see, what opportunities do you see with expanding doula services to vulnerable populations in Texas, specifically as it related to payment? Well, we know that our local legislators and even the federal legislators have been working on this for a long time, is getting those doulas and certified nurse midwives reimbursed properly and quickly and at the highest tier, right, Deandra? Because people don't understand how CMS works, how the reimbursement works. There's multiple tiers on what you can get reimbursed for. So one of the things that North Harris does is that we focus on legislation, and so does Children at Risk. Legislation. How can we change legislation so that it can directly affect these outcomes? And it ties to reimbursement. We know that prior to women delivering in the hospitals, lay midwives deliver those people and in their homes. And we also know that the maternity mortality rates were lower during those times. So essentially, doulas and midwives became competition for physicians. And so That's a whole different conversation, but it's almost like, hey, we're not your competition anymore. We are your partners in this, and let's partner together so that we can mitigate these maternal mortality outcomes, because we know that if you look at the statistics that are out there from CDC, African-American women or Black women are 3 to 4 times likely to die. And the Hispanic population, right, although they are a minority, their rates have lowered over time. And I'll just be frank with you, one of the things that has affected that is that the distrust in the healthcare community, and I think I see that question later, it has caused them to no longer seek that care in the hospital. They're delivering in their homes. So that's why their rates are dropping, right? We still believe in modern medicine, and so we go to the hospital. And we don't understand that there's power in advocacy. And so we need to understand that we can challenge healthcare providers. And so that is what I believe doula services and midwives partnering with the physicians, and for them to say, hey, let's get them their reimbursement that they deserve. And so maybe that work we will get that reimbursement increased, and the doula services are expanded to those vulnerable populations. Can you talk a little about the distrust? That was the very next question. Yeah, there is a distrust in between healthcare providers and patients, right? We know what the root cause is. It's simply systemic racism. And we know that that's going to take a long time for us to kind of undo that, because what we really know in healthcare is that socioeconomic status and education does not decrease your risk for maternal mortality. Okay, so that distrust is a deep-seated thing that we're going to have to chip away at that, which is what we're doing today, one at a time, right? To let you know that you most certainly can advocate for your care. If you don't understand or believe that your provider is giving you that best care, you can say, I'm sorry, I would like to choose another provider. Just because that provider is giving you a recommendation doesn't mean that you have to use that recommendation. You can always ask for a second opinion. Never go to the hospital alone. Okay, take someone with you when you go, because typically when you have a person with you, as clinicians, we feel like, okay, this person is not alone. They have a supportive person. We don't know if that person, we don't know who they are. They could be a doctor, a nurse, a lawyer, a social worker, somebody who knows something about what we're doing. So we're less inclined to kind of give out, just the general basic information for that. We have just a little under 3 minutes left. Okay. Challenging. It looks like a lot of these, they're asking about depression and anxiety rates compared to other countries. Of course, I'm embarrassed to say that the United States is probably number one. We have the highest of anything, maternal mortality, just anything across the board. America is the number one, okay? Just know that. There's other less developed countries that are doing far better than we are, and that's across the board. Okay, so we're at our 3-minute mark. So Carolyn, would you like to do our closing remarks?
Absolutely. This was so fantastic. I feel like I learned so much from you guys. Also, you got through so many questions so quickly.
I was trying to work the clock.
Hats off to you. Huge thank you again, Dr. Nicole Townsend, Deandra Willis, Dr. Teresa Morris, Michelle Harrell. Thank you so much. Like I said, I learned a lot. I think that there are some requests in that Q&A that we'll try to get to. Also, please feel free. I'm sure all of our speakers are happy for you to reach out to them directly if you had individual questions for them. Like I saw some requests for a link to specific research and things of that nature.
Yes.
Please, we would love to do similar events like this in the future. So if you enjoyed this event, please complete the survey, give us some feedback, and then that will help us to continue these roundtables focused on motherhood and maternal health. So please take a moment, take out your phones, and then you can just use the QR code to complete the survey. Also, we have a lot of fantastic learning events for the rest of 2024. So you can also use this other QR code, or you can go to our website and see those learning events. They are all free. We hope to be a resource for everyone on this call. And with that, we're reaching our time. Again, huge thank you. And I hope everyone gets home safely in the storm. All right. Have a wonderful afternoon.
Thank you.
Thanks, everybody.